Done. Okay. Hello, everyone. My name is Beverly Mishkin, Director of Senior Services and Case Management at Jewish Family and Children's Service of Greater Mercer County. We appreciate you taking the time to join us for the webinar Hospice, Myths, and Truths, sponsored by the Secure at Home program through JFCS and presented by the Greenwood Hospice Team. We are pleased to offer the opportunity to explore hospice care. Secure at Home is one of our senior service programs designed to help older adults age safely, comfortably, and independently in their own homes. Our geriatric care managers provide an umbrella of services to promote healthy aging and aging in place. JFCS offers additional senior services to members of our community. We help seniors age in place and have access to the services to stay in their homes for as long as they wish. Seniors find healing through support groups to work through age-related challenges. Tailored social and educational programs, as well as senior nutrition programs, ensure that the needs of our older adults can be met. Please welcome the following Greenwood Hospice Team members who will present today. Joy Simons, RN, and Case Manager and Admissions Coordinator. Edwin Arevalo, Chaplain and Spiritual and Bereavement Counselor, and Marcelle McGovern, Licensed Social Worker, Medical Social Worker. Before I turn the presentation over to our presenters, please know questions can be submitted in the Q&A or chat at any time and will be addressed following the presentation. This presentation will also be recorded. And now I give you the Greenwood Hospice Team. Thank you very much.
Great. Thanks, Beverly. So we find in our work in hospice out in the field that there's a lot of misunderstandings about what hospice is. There's a lot of myths. So that's where we're starting from today. We're just going to cover the myths and the truths about those myths, and then we'll open it up to questions at the end. We'll cover any questions that people have about the presentation or beyond about hospice. We have the honor of working for Greenwood Hospice, which is a small nonprofit hospice, which means we have a lot of personal time with our patients. We are able to do a lot more legacy project work and bedside time than most hospices. So we have a little unique viewpoint on hospice because we really think it's about quality of life. We really want to give people as much living as possible, to live as fully as possible. So we're coming from that perspective. And Joyce will, our nurse Joy Simons will be joining us at the end for the question and answer because she got called to a new admission. So I'll start with just myth number one, which is hospice is a place to go to die. A lot of people think it's a place, like they're gonna go to a place. Their experience with hospice might have been just with a person in the hospital who then went to a wing of the hospital that might have been inpatient. And in New Jersey, especially, hospice is a service. It's mobile. It's not a place. So hospice is a specialized form of care for a person who has life-limiting illnesses in the end stages of their journey. And hospice care is delivered to them where they live, whether they call home, whether that's skilled nursing facility, assisted living, or at home. We come to them. We bring all the services to them. Myth number two that we bump up against is that hospice is giving up on someone. We hear this often from family members that they feel like, I'm not ready to give up on my loved one. And we have to gently educate them. Just let them know that hospice is a choice for comfort and pain relief. It's not just leaving someone to die. It's not just letting someone atrophy. It's giving them extra medical attention just when medical treatments can no longer cure a disease. Our hospice care professionals do many things to care for the person, including pain management, reducing anxiety, offering spiritual and emotional support, improving the quality of life for the terminally ill people and their families. And we really respect that a patient has the right to have their pain controlled and well managed at the end of life. So that's the focus. It's really comfort and pain relief. Myth number three is that hospice means no more medical care. This is not true. Hospice provides the highest standard of medical care for comfort, including medications and treatments. The hospice team includes a patient's personal physician, our medical director, who is also a physician, our registered nurses, LPNs, other professionals who work closely with the patient, our home hospice aides, and we work closely with the patient and the family to make sure that we provide medications and palliative treatments to relieve pain and ensure comfort of the patient. Now, sometimes doctors will DC or discontinue medications that are no longer relevant for the very end of life and might be taxing someone's liver more than is needed. So that the doctors will make those decisions that maybe some things are not necessary and we want to just really have the comfort medications be more effective. The nurse Joy can talk more to that at the end. But for most patients, hospice does mean less hospital visits and more care by the medical professionals at home, the nurses, as well as home visits from our medical director or sometimes families, private physician. So a lot of people get tired of going to the hospital because especially right now during COVID, it's not an easy experience and families get separated. And so we do as much as we can to make people comfortable at home. Myth number 4 is that hospice hastens death, that somehow we're moving things along. And I think this comes from movies where people see someone on an IV drip in a hospital wing of a hospice department, and they think that we're just, over-medicating them until they die, which is not true. Hospice is about quality of living at the end of life. We try to keep people as alert as possible to enjoy as much of their life as they can, but also controlling pain and symptoms at the same time. So it's a fine balance. The goal of hospice is to make the quality of a patient's life the best it can be in the final months, weeks, and days. There are no studies that indicate that hospice can hasten death. There are studies that show some patients live longer actually when receiving hospice services because they're getting more personalized attention. Hospice is for cancer patients. Some people just hear hospice, they think cancer, when in reality, hospice manages multiple disease states. So it's for all persons with advanced illnesses such as cancer, heart disease, stroke, lung disease, liver disease, kidney disease, ALS, Alzheimer's disease, multiple sclerosis, AIDS, and other life-limiting illnesses when the conditions begin to worsen and enter the final stage. Myth number 6 is that hospice is limited to 6 months or less. So the truth is there's no limit to the time that Medicare will cover a patient on hospice. Hospice is for patients when they sign on who are expected to live 6 months or less. That's if their disease progresses on the average trajectory. And hospice can be extended if the patient remains eligible for services. So say they're slowly declining over time and they continue to eat a little bit less, sleep a little bit more, they will stay eligible for services even if it goes beyond the 6-month mark. That's an educated guess in terms of the doctors, and so it's not a hard and fast rule. Some studies have shown that in many cases, patients who enter hospice can, if they come in earlier, at closer to that 6-month diagnosis mark, they live 25% longer than hospice eligible patients who do not receive hospice care. Myth number 7 is that hospice is somehow expensive. That is so not true. Hospice is an all-inclusive benefit covered by Medicare, Medicaid, private insurances, and HMO together. Under Medicare, if someone has Medicare, there are no copays for any of the doctor visits, any of the nursing care, medications, hospice medical equipment, or medical supplies that we provide related to the patient's terminal illness. Anything related to that terminal diagnosis is covered. I'm going to hand off to Edwin from here.
Hi, everybody. I'm Edwin. I'm the chaplain, and I'm going to take over the last several myths. Is there feedback? Myth number 8 is you may have to turn your volume down. Yeah. We just want to make sure there's not a feedback as I'm speaking here because we're in the same room. I think that's better. Can you hear me okay? I think they can hear me. Myth number 8. Oh, can you go back to 8? Myth number 8 is hospice excludes patients' personal doctors. And this is not the case. In many cases, the patient's personal physician can choose to be part of the hospice team. And the hospice medical director has extensive training in end-of-life care and will work closely with the patient's personal physician to ensure quality of life care and comfort. So the patient, the family will have both their own doctor and the hospice physician as well to be able to support the patient and the family. Myth number 9, can you go back one? Yeah, myth number 9 is hospice will starve a patient to death. And this is also not the case. Hospice allows patients to refuse food and fluid, but it's not the case that a hospice patient will not be given food at all. It is a natural progression of the patient's terminal disease that interfere with the body's ability to process foods and fluids, which often brings about pain for the patient. But hospice understands that a terminally ill patient will begin to eat less and drink less, and this is the process where they begin to sort of decline. So hospice helps to prevent additional pain by honoring a patient's declining need and desire for food and fluid. Myth number 10 is that hospice equals euthanasia. Hospice neither prolongs life nor hastens death. So euthanasia is a purposeful mercy killing to end suffering, and hospice is not that. So when hospice comes on board, it doesn't mean that the end is imminent. It could be in some cases, but it doesn't mean that hospice will end the life of the patient. Hospice care is focused on providing pain control, symptom management, social, spiritual, and emotional support to help a seriously ill person live in comfort with dignity until they die. Myth number 11 is hospice patients are in bed waiting to die. And hospice patients are not, that's not the case. In many cases, hospice patients are encouraged to live life fully. But in many cases, especially a lot of the patients that we see, that's not the case. We go into homes, we go into facilities, and you can sit and have a full-on long conversation with a patient as they are progressing in their terminal disease. So the priority of hospice care is to help people with the terminal illness have the fullest possible life with freedom from pain, discomfort, and to maintain mental awareness for as long as feasible so they can spend more quality time creating special moments and new memories with family and friends. Myth number 12 is hospice is no place for families. But the reality is hospice includes family involvement. So we as a team here at Greenwood, we will very much partner with a family. In the cases that we're seeing now with the pandemic, with COVID, in many circumstances, a family may not be allowed into the facility because of COVID, but that does not mean that they are not involved still with the care of the patient. And it also does not mean that we are not involved with the family in the care of that patient as well. We will go, we will meet with family members if we need to with them at their homes, or if they live in states that are further away, we will call them. We've had hospice patients where their family members lived in Hawaii, and we stayed in close contact with them, and we're made sure that they were involved in the involvement of the patient and their care. Myth number 13, hospice care ends when the patient dies. And this is especially where I come in as the bereavement coordinator for Greenwood. Hospice offers bereavement services and support up to 13 months after a patient passes to the family. And in some cases, even after 13 months. It doesn't necessarily have to end at 13 months. In fact, I have a family who their time, technically was supposed to end this month. They died last year, and their 13 months were coming to a close this November. And I am still meeting with the wife on a regular basis once a month. And that's not going to end anytime soon just because the 13 months have come up. So we continue to offer bereavement services for family and for caregivers if they so choose for up to a year afterwards. And that can include anything from letters to cards to bereavement materials to counseling services. And the best thing is that this is absolutely no cost to the family members whatsoever. And then our last myth is hospice means strangers care for you. And this is also just not the case. A dedicated team of hospice professionals support the need of each patient and caregiver. So we here have a team full of caring individuals, from social workers to volunteers, to myself as the chaplain, to our nurses. And we do not come in and sort of just take over. Hospice educates family members and caregivers to serve as the primary caregivers for end-of-life patients. And we work with the family to keep the patient comfortable, free from pain, and help arrange support needed to keep the patient at home. In some cases, the patient, would rather stay at home, and so we ensure that that's provided as well. We also have aides that can help with the care at home. So these are some of the main myths that we have encountered, that on a daily basis when we're speaking with family members, we're having to educate and say, not necessarily hospice does not necessarily mean this, but it does mean this. And so we wanted to be able to provide that for you. So I'm going to open it up now to see if there's any questions about anything that we presented here, or if there's any questions that you just may have altogether as far as questions regarding hospice, even if we didn't touch upon them here.
Okay, I do see a question. How is a determination made for a patient with dementia? And generally there are criteria set by Medicare, and I wish Joy was here because she's better at telling you the exact criteria, but they look at how many ADLs, assisted activities of daily living, a person can no longer do for themselves. And they look at things like how well are they swallowing. Generally, they have to be down to about 5 words or less, like they can't be talking in sentences and paragraphs to qualify for end-stage dementia. So generally, it has to do with their swallowing ability, their speaking ability, and they no longer can do their regular activities of daily living. I also see a question here that says, how much care is provided by aides? So Medicare just gives a chunk of money per patient, and each hospice determines how much they're going to give. Some do 3 days a week. We do 5 days a week for all patients. So all patients get an aide for 1 to 2 hours a day, 5 days a week. If they're in a facility, they might only need an hour. If they're in a home patient, they may need that full 2 hours of assistance. And then we also provide volunteers in the home. And for those who are comfortable with COVID protocols, everybody on our staff gets tested every week, and we all go into the home if people want us to. We go into facilities as well. So the aides that help with things like bathing, dressing, feeding, it could be just companionship. We have a couple patients we've helped do their memoirs and their words of wisdom. I do a lot of words of wisdom projects with people, and the aides might just sit and read those if the person does not need physical care from them. But most of the time, our aides are providing that kind of morning care that people need extra assistance with, or an extra person to help lift them. I see another question here. What's the difference between hospice and palliative care? That's a great question. And we currently do not provide what's called palliative care, which is a broader umbrella. So hospice is underneath that umbrella. Palliative care is not time limited. So there's organizations that do provide palliative care with a doctor and a nurse, and sometimes a social worker, but they do not get an aide, they do not get a chaplain, they do not get the extra support that hospice provides at the end of life. So palliative care is just general care for someone who is facing a terminal illness, but they may not be at the end of that journey. They're more at the beginning of that journey and their diagnosis.
If I could just add also with palliative care, the patient can be still getting treatment with palliative care. With hospice, they're not getting active treatment. In palliative care, they will be getting active treatment. So that's one of the main differences between the two.
Okay. I see, does Aetna provide coverage? And it really depends on the policy. Some people have purchased long-term healthcare insurance. Some people don't have that included in their insurance policy. So if, say, you're under 65, you don't have Medicare, you're not on disability, and you don't have Medicare at all. There are times when Medicaid does cover a person, a younger patient, but Aetna, it's all based on the actual insurance policy would have to be run to tell you whether it has the hospice benefit. There's a question here about talking about the legacy projects we offer our patients. So one of the really amazing things that I get to do is interview anyone who is verbal enough to participate for their words of wisdom. Sometimes I get them one phrase a visit. Sometimes Edwin picks things up or the aides pick things up from people and we put those in their words of wisdom. I compile them on different topics. So things like, words of wisdom for your grandchildren or your nieces and nephews on education, on romance, on forgiveness, on living a really good life, on travel. So I just ask about a lot of different topics and people will share their words of wisdom and then I type it up in a one-page document and put it on scroll paper, frame it, and then give copies to the family. And not only does the patient find it really meaningful because someone cares about what they have to say, someone says you're still of value, you have something to contribute, you have wisdom from just living your life. Some people laugh at me, they say I have no wisdom. I said everyone has wisdom that's an elder from their life experience. So it honors them, but it also, I think, provides the family with something that they can share also in a memorializing way once the person has passed. And it's been used a lot that way. And if someone has gathered things for memoirs, we will help them bind their memoirs. We'll help them assemble them. If they have a pile of poetry, we might bind that and put it into a book. If they have a lot of artwork, we might scan the artwork and put that together to share with the family. Right now, we're working on one for one of our patients who is a stroke patient who can't do this herself. So we are contacting through her son all of her friends and family who've traveled with her, who've done work in Israel with her, who've done work with local charities with her, and putting together a legacy website. One of our volunteers is doing where everyone can share their stories and their photos and their experiences in real time with this patient. So hopefully she'll get to enjoy it some, but it's also just for her greater community and family to connect around just celebrating her life now before, not having to wait and really just honoring all of the beauty of her life. Ed, do you want to answer how can a family know that hospice is appropriate for a person? Let me answer that? Okay. So how can a family know if hospice is appropriate? We can do an evaluation at any time a doctor feels it's appropriate. So we have to have a doctor's order. So a family can say, mom has slowed down, she's not eating, she's not as much as usual, she's sleeping a lot, she looks like she's declining or in a lot of pain. And if you see any of those kind of indicators of decline, then you can easily contact the doctor. If the doctor agrees that someone is going through a chronic illness, a chronic state of decline, they can call hospice. You don't have to wait till someone's, what's considered imminent within 7 days of dying. At any point, a doctor can order a hospice eval, and doctors are pretty skilled in knowing what the criteria are for that. But you can always ask, on behalf of a loved one or for yourself, for a doctor's opinion about that in terms of a chronic diagnosis.
So one of the next question is, do you insist that a patient know she is in hospice? Some families don't want the word hospice mentioned. How do you deal with this? So the quick answer to this is no, we don't always have to use the word hospice. In fact, we had a patient, a family just come on a little bit ago that did not want to use the word hospice, and so we honored that request, and we did not use the word hospice with the patient. The patient is actually still with us. However, more often than not, the desire for a family not to use the word hospice has more so to do with the family coming to grips with the terminal illness or with the fact that the family member is dying. And it really doesn't have to do much with the person who's on hospice. So one of the things that I'd like to do as the chaplain is sort of, dive into that a little bit and see if we can't help the family sort of come to terms with this terminal illness and how it's affecting the family dynamics, or how it's even affecting their relationship, their spirituality, really, in terms of this terminal illness. But that does not mean that we're going to supersede and say, no, we're going to use the word hospice. If that's a wish of the family, we won't do it. We won't use it. We can go into a room and say, hi, I'm Edwin. I'm the chaplain. I just wanted to come and visit with you. Or, Marcelle has gone in and said, I'm Marcelle. I'm the social worker. I work with Dr. So-and-so, whoever the doctor is that is visiting, and we can just approach it that way. So, yeah, the word hospice doesn't always have to be.
There, now you can hear me. Can you hear me now? Are we able to provide family members with resources to help their loved ones eat or do other activities? And yes. So with home patients, we have a nurse case manager, and she directs plan of care for any physical or medical needs. So I set plan of care for the emotional, social needs of the family. And our nurse case manager generally provides, she supervises the aid, and they set the plan of care. So I'm going to actually have Joy, our nurse case manager extraordinaire, and admissions specialist, answer this question. So they're asking, are you able to provide?
Yeah, so I mean, what Marcelle was talking about a plan of care. And so the treatment and the plan of care is really going to hinge on what me as the case manager, when I go in, I'm doing a full assessment, I'm getting the particulars about the patient and what their particular needs are. So that's, all the different aspects about the physical, whether it's needing supports for ADLs, including feeding, whether it's getting help for taking medications if this is a home patient, whatever the different aspects are that the patient needs help with for their physical well-being, that's going to be part of the plan of care. And so it is my role too, as the hospice case manager and the admission coordinator, to figure out, where are the needs, how can we support them, and how do we keep updating that? Because as we know, a patient's condition changes all the time. So this is going to be timely and updated quite often, or as much as needed. So it's not cookie cutter where I come in and I just put a plan of care without meeting a patient and finding out what's important for the patient and their family, and just keeping it that same plan of care through the whole thing. This is a very fluid process. What if the person doesn't have any family to act as caregiver and the patient wants to be on hospice at home? So that's a good question, and I get this quite often. So hospice as a benefit is really an addition to natural supports. And what I mean by natural supports is when we come in, it's already either to provide support to somebody who's either getting care at home, maybe hired caregivers and family, or in a long-term care facility. So for that person who doesn't have family to act as a caregiver, we have to figure out what those natural supports are going to be. So if there is somebody working as their advocate, it's going to be important to get set up what the caregiving is going to look for, because we're an adjunct or additional support. We're not the main support. So if this is somebody who is coming out of a hospital and can no longer live alone safely, it needs to be set up, like I'm saying, like maybe an advocate or an extended family member. Somebody has to help to figure out what those supports are. And we're going to add the additional stuff. So hopefully that helps a little bit with that question.
So there's another question here that when my father was in hospice and I was his caregiver, the hospice staff refused to meet with me unless my father was also participated in the meeting. Are you willing, what is Greenwood's policy on meeting with caregivers without the patient present?
So if the caregivers, I mean, obviously they need to be part of the plan of care is my stance. They're the ones providing the care. I'm not sure, unless there was some type of issue where the patient was able to self-direct their own care and was really a loud enough spokesperson and was saying, you only talk to me and nobody else. I mean, really, that's quite opposite of how we work in our hospice. And what I just got off the phone with family members questioning about hospice now. One of the explanations about hospice, in traditional medicine, you've got a physician who does the assessment and comes up with a plan of care. And it's the doctor in the center of things deciding what's best for everybody. In hospice, while the physician is part of the team, who the first most important person is the patient, if they can speak for themselves, but also the family and caregivers, because this is a team effort. So we need to find out from everybody involved what's important for the plan of care. It's not necessarily to fix an illness anymore. In fact, by the time we get to hospice, the philosophy really is about comfort and support as a natural process is occurring, not to fix an illness, but just to manage symptoms as they come up. So it would be very important for us to include the family member, the caregiver, whoever is involved in that day-to-day really should be involved in that process.
It's not necessary for every conversation to happen in front of the patient. And we don't consider that appropriate. There are times when it's like more upsetting, like in the example Phyllis just gave here, where, her father was smearing the bathroom with feces and had diarrhea from laxatives and would be embarrassed that people are talking about that in front of him. We don't want anyone to feel shame or embarrassment. So if it's something where we just need to come up with a solution, a strategy for a patient, particularly with dementia patients, we would step outside and have that conversation out of earshot of the patient, just to come up with a strategy for how to work with them, and then include them, and then explain to them what's going on. A lot of people don't explain enough to the patient, but we certainly would not have to have we don't have a policy about having every conversation in front of the patient, because there's certainly times when that doesn't feel right.
Are not serving a good purpose for people in general. We've got the human condition, which is variable. So we can't have a set policy to say that we're always going to do it this way or never do it that way. It's all going to be, considering each unique situation.
Are there any other questions? Oh. Okay. Can you hear us better when we're closer?
Oh, so how quickly can you respond? Well, I mean, essentially, depending on what the situation is, I can pretty much respond within a few hours. You know, our office, we're available 9 to 5. We have a nurse on call 24/7. So depending on the situation now, hospice is not considered an emergency service. But, you know, if somebody really feels that this is something that needs to happen quicker, you know, we're going to consider all that and we're going to make it happen as quick as possible. I would say, though, realistically, it's probably within 24 hours, you know, give or take what's happening with the situation. Once somebody is signed into hospice, you know, and already on our services, then we have an hour response time for anything that is being called for. And we have that 24/7 accountability with the nurses.
I think I'm going to also address this. We didn't completely finish addressing the question about what if someone doesn't have any family at home and they want to stay at home. And sometimes people can afford to hire a live-in caregiver through a private agency. Some people cannot. So it's a matter of whether they can be safe enough at home. So we do have to do safety evaluations to see if someone can be safely at home. And we have had patients who spent their end time at home with family members coming in, friends coming in, neighbors coming in, and our aide coming in. So as long as they can be safe at home, which I know you guys provide a lot of support for through Jewish Family and Children's Services, through your Safe at Home program, if they can be safe at home, then of course they can be on hospice at home. But we do have to evaluate that situation to make sure it's a safe situation. Still can't hear us well. I don't know what's happening. My volume's all the way up. Okay. Are there any other questions? I'm looking at the chat. Let's see if there's anything else. Okay, well, if there's no other questions, we can just tell you a little bit about, maybe Joy can just do a little overview of what the hospice team includes, so you know what comes with the hospice benefit, and then we'll put our contact information back up. Here we go. Hold on a second. I'm not sure how to share a screen with that.
Right.
Okay.
So again, and I think this probably was discussed a little bit, but you know, hospice is mind, body, spirit. It's not just the physical part of the body, you know, or one component. And so it's a team effort with hospice. So for the physical end, that's myself as a hospice case manager, the admission coordinator, and any of the other nurses, including we have an LPN who also does visits for us. That's the assessment component and figuring out plan of care with everybody. We have our nursing aides, our CHHAs, who provide up to an hour and a half, 2 hours, Monday through Friday for added support. Sometimes we have volunteers who are also assisting in some of the physical components of care. We also have the attending physician, and it may be one and the same for who our medical director is, Dr. Burrell, or it can be, you know, a combination of Dr. Burrell as our medical director and the person's attending physician. So that's basically the physical end. Then we've got the psychosocial, which is Marcelle, our social worker, and then some of our volunteers. And that kind of spills into bereavement, which then is the spiritual with Edwin, and again, might be some of our volunteers. So, we try to do it as a component of the mind, body, spirit. And it's always the team effort. Every 2 weeks, we are getting together formally to go over plan of care for everybody and making sure that we're all on the same page and making sure that we're addressing everything that needs to be for a patient. Informally, we are conversing amongst ourselves, all the time. And on top of that, because we're an adjunctive or additional support, if somebody is in a facility, we are also coordinating or collaborating with the facility staff. So it's always a team effort.
Were you guys able to hear all that? I don't hear anything now. If there's anything left.
Well, I, for one, apologize for coming in late, and I'm going to duck out now. I'm actually being called away for some stuff. But, I always appreciate our collaborative effort, and good to see you all.
I wanted to also let you guys know that we're starting a new music program based on the Alive Inside program. So we're interviewing families for what their loved ones' favorite playlist would be, especially for our dementia and Alzheimer's patients, Parkinson's patients who might be nonverbal at the very end, and just wanting everyone to have access to music. So for particularly in skilled nursing facilities, to have it may be a CD Walkman, it may be a little MP3 player, it may be on the phone. For our aides, our aides often help people call their family members from bedside, because during COVID it's so hard. So many people cannot visit or don't feel safe to visit or have to only do patio visits and can't. And so we're trying to bridge that gap as much as possible, bringing music, bringing conversations with loved ones, speaker phones, Zoom calls, that kind of stuff. So all of us in the field offer that when we're bedside, which I feel really good about. We have a really tech savvy team that is able to, bring people connected as much as we can while we're out in the field. So thanks for the opportunity to talk to you guys and share a little bit about what we do.
I want to add also, as far as from the chaplain point of view, the spiritual point of view, I am an interfaith chaplain, meaning that I am trained and educated in multiple faiths. So I go in with the patient's religion and spirituality in mind, not my own, not with a hidden agenda to try to get them to go to church or to make confession or anything along those lines. I go in seeking how I can best support them with their faith belief. And sometimes that includes a faith belief that is far different than mine. And like I said, it is not about my faith, it is about their faith and how that faith impacts or how their terminal illness is impacting their faith belief. So quite often I do have Jewish patients and Catholic patients, and I've had Buddhist patients, and I've had atheists that I've supported as the chaplain. And I've been able to do so, again, because I go in with their spirituality in mind. And that's important. It's important for the family members. It's important for the patient that at the end of life that they are holding on to what was important to them when before that, and that is faith and spirituality. So, just something to keep in mind.
So there was a question about where we're located, and our office is in Ewing, and we drive all over Mercer County. We even have a facility as far as Galloway down near Atlantic City. So hospices generally are mobile across the state. We focus mostly on Mercer County. We do go over into Monroe and sometimes north of there, depending on need. And so, there's another question about whether you should pick a hospice in your community. I think it's helpful to know that your on-call nurses are close by. So if someone's, if a hospice is located 3 hours away, you want to make sure that you have on-call nurses that can get there in 20 minutes, because our on-call nurses all live local. So that way they can get out there and help immediately. If a family, especially for families at home, I think it's really important that someone, be nearby and responsive. Even if it's just a simple question. Sometimes caregivers just get overwhelmed at home. Sometimes it's just scary in the middle of the night when you might hear a breathing change, or someone's not swallowing quite the same, or something new comes up, a new symptom comes up. So I think it's really important that there's quick response time. I think that's the most important thing. Let's see if there's any other questions. Okay. Edwin, you have a question. Do you work with any other clergy?
Yes, I can work. So the question is, do you work with any other clergy? That's for myself as the chaplain. Yes, so I will. In one of my first meetings when I meet with the patient is an assessment and evaluation, and so I will assess the patient for their level of spirituality and how that's impacting their terminal illness. But I will ask questions such as, what was their religion, what was their spirituality, what church did they attend, do they still attend? And again, that's with no sort of judgment or condemnation. If they said, no, I haven't gone to church in X amount of years, you're not going to get the, oh my goodness, you need to go now. That's not it. It's mostly so that I, with the family or the patient's permission, would be able to contact that church and say, did you know that you have a parishioner that is, on hospice? They are asking for, whatever it is. A lot of times, many of my Catholic patients will ask me to call their parish and have them come in for sacrament of the sick or communion or something along those lines. I have also called a few synagogues in our area and spoken to some of the rabbis and have them come in to do visits as well. So I do work with other clergy. I can work with any church. I can work with any minister, as long as the family and the patient allows me to do so. I will not contact a church and I will not contact a pastor unless the family or the patient gives me the okay to do so. Otherwise, it's a breach of their privacy if they don't want that. So I only do that if I am given permission from the family.
We have a question. What if a patient has dementia and he refuses or asks care that's different than from what the family wants? How do you decide? That's a really good question. Generally, if a patient has dementia to the point where they're unable to make their own decisions and their family, they have, say, a living will, and they've listed a healthcare POA, healthcare proxy, to make their decisions for them. And that is engaged because they're no longer able to make their own decisions. They do not sign their own hospice consent forms. Their family member, let's say their daughter, signs the consents. The daughter is the one that's going to make the primary decisions on behalf of the patient. So the patient themselves, though, we want to work with them. Obviously, sometimes a patient doesn't want to, have, say, a bed bath. We have a lot of resistance with patients with dementia to showering. So we might do a bed bath. If they don't want a bed bath, then we might do it a creative arrangement with a commode. I've seen the aides do, and do like a pouring bath. So we try to figure out what the resistance is. If it's a fear of the shower, if it's a fear of, like say it's a fear of a woman seeing them naked, we might have to reassign a male aide to a male patient because they're they haven't said, but they're too embarrassed in front of the female aide. So we try to work with each family is different, each patient is different, but we try to work to find a solution. I see do most primary care physicians participate in hospice for their patients, or do many not want to participate? I would say the majority of our primary care physicians stay on with their patients because they've had them long-term, and they have long-term relationships, and they want to continue to be involved in the decisions. And so we go to them for the medication recommendations and the checking off of every plan of care and every change of that plan of care. So the majority of them do want to stay involved. Every once in a while, we have someone who just doesn't have a primary care physician, or the primary care physician doesn't want to be that responsive once in a while. And so then our medical director, Dr. Burrell, he will take on that patient, even though he's full. He's a gerontologist. He has a full caseload of his own private patients. He will take on our hospice patients if they don't have someone that's willing to follow them. And he will also do home visits if needed to, say, change a catheter, or just work with the patient. Maybe a patient's really scared and they want to speak to a doctor. So he will do home visits for those patients. I hope that answers that question. And we also are hoping, I know the question about clergy was aimed at Edwin, but we're also hoping to do some grief groups and memorials with other clergy like yourself, Beverly, with other chaplains, with other, religious leaders, just to have, especially in assisted livings like Abrams and Acorn Glen and places like that. Often they don't have a chance to grieve, to come together and talk about somebody who has passed. And even if they're not on our hospice, we just want to provide that space for people to process how they're feeling. It's really hard during this time of COVID because they don't want gatherings. You don't want groups. You don't want to bring people tight together. So we're trying to find creative ways we're trying to put together right now Zoom memorial ideas and Zoom grief share groups and things like that, so that could be a platform possibly for people to have that need met. And I would love to collaborate, with Beverly and others on that kind of thing. Okay. Just looking to see if we have any other questions. We also have an amazing volunteer corps. So, unfortunately, a lot of the facilities, skilled nursing facilities and the assisted livings, are not allowing volunteers in. But they've been putting up bird feeders and filling the bird feeders outside people's windows if they're on the first floor. They've been Zooming and playing the piano and singing to people through our aides or, our staff cell phones. They have been making posters to decorate people's rooms. If they're at home, they might be dropping a caregiver care basket off of baked goods for the family, or doing gardening work, yard work for them, doing errands for them. Going in, beginning of COVID, it was standing in line at Wegmans for some of the home patients who couldn't get out and go get groceries, just to save them that extra expense and that extra time. So we still have volunteers that are doing these activities. We have one handyman volunteer who actually goes into homes and he will change light bulbs. He'll fix small things that need repair. And we get all of our aides, our nurses, our staff, we're all COVID tested every week. If a family wants that for their volunteer, if they want to volunteer in the home, we will get the volunteer COVID tested. We have a CNA that's a volunteer who's learning how to be a nursing assistant, wants to eventually become a nurse. So he's shadowing some of our aides as well. And he gets tested every week. So we have people who work from the office. They make phone calls. They help with just checking in with family members, seeing how they're doing in bereavement, or just seeing how they're doing in caring for their loved one at home, seeing if there's any way that they can be of assistance. So I'm really grateful for our volunteers. We have a great group. Each hospice does have a volunteer program. When hospice was started, it was really very volunteer driven. There were very few paid staff at the beginning of hospice until Medicare started funding it. And now it's more medically driven, I would say. It's funded, and the case manager, the nurse, is at the core of the decision-making of the team, but we really still are required to have a certain number of hours of volunteers with every patient, or is supposed to have a volunteer. Now, some families waive volunteers, especially during COVID. They just don't want any extra people in the mix. That's okay. They don't have to have a volunteer, but we try to create creative ways for them to stay engaged. So like making a playlist, for example, interviewing over the phone, some family members finding out music that the person likes, and they can do that at a distance, or they can write up a bio and create a legacy page at a distance. So each hospice does have a volunteer program. When I'm out in the field, I honestly don't run into any of those volunteers. So I don't know how active they are at other hospices. I just don't come across them. I see other nurses, I see other social workers once in a while, but I just don't run into them. I have been told by some of the facilities that they're so shocked at how much I communicate and how much we're in the field and talking to them, because they say they usually don't see a lot of the hospice staff. They just fly in and fly out. But we really try to communicate well with everybody, especially home patients. I think the whole family. Sometimes I've done Zoom calls with granddaughters in Israel because they couldn't fly because of COVID, and they were really having a hard time with their grandfather passing. And so we extend far beyond just the patient and reach out to people who are in need in the entire network, in the entire family. Sometimes it's an aide that's been with somebody for a really long time. It might be a private aide that's been with somebody for years. And as the patient is declining, they feel like they're failing. They're not doing their job. They're not making the person better. And we sit with them, we spend time with them, we educate them on the end of life signs, we give them some extra support bedside, and we provide them bereavement support as well if they need that. Okay, I don't see any other questions. So I'm just going to put our contact information back up. If people think of questions after the Zoom chat, if after the call, that they can always call our main number. They can, ask 9 to 5. I'm here or available by cell phone in the field. Let me put that on share. Hold on a sec. And share screen. There you go. So we will be happy to answer any questions that didn't get answered today. And we also have a nurse on call after hours if someone just really has a burning question about a loved one and how to maybe engage the process of hospice. You can always call this number. It will connect with our answering service at any time.
Marcelle and Ed, can you hear me?
I can't hear you, Beverly.
Oh.
Okay. Now I can hear you.
Okay. Marcelle and Edwin, I just want to thank you for this presentation. It was really informative and interesting and really a lot of good questions. And we thank everyone for attending. And we look forward to further collaboration. And I just want to also say that JFCS is proud to continue offering our full services in line with health and safety guidelines during this challenging time. You can learn more about our programs, including webinars and resources, at www.jfcsonline.org. We want to wish you all a safe and healthy holiday season, and we thank you again for coming and presenting today. Really appreciate it.